their server, the performance is really good, but it is, how do I want to say? It runs, I think we've got 2 hours for the duration. So
well, that way, if I go a little bit over, we'll be okay.
Yeah,
I'll try to go fast.
There is a time limit, but it's pretty long. So.
Oh yeah.
Anyway,
I think if I get to 2 hours here, I'm going to be putting everybody to sleep because it's an important topic that we all need to know. But oh my gosh, is it dry? And there's really no way to really spice it up either.
That's right. So we have 61 people registered so far. 16 have logged in. So we'll give it here, like I say, probably 2 or 3 minutes for everybody to log in.
Oh yeah, I see a lot of people joining already. Awesome. It's okay, Jennifer. We haven't really started yet. We're giving it a few minutes for everybody to get in. Can you hear me now? Susan, can you hear me? I saw you ask there too. Okay, perfect. Giving it just a few minutes for everybody to get in here.
I'll make a few opening comments here, Tom, just to kind of orient everybody here.
Okay.
Yeah. So welcome to the webinar. And as you know, Tom is going to be presenting on the ACNS terminology. The session is being recorded, and in about an hour, you'll get an email with a link to the evaluation form, which needs to be completed for submission to ASET for CEUs. So I'm going to sign off and let Tom continue on here, and I'll let things roll. And at the end, I'll come in and address any questions that may come up.
All right. Well, thank you, Jeff. We'll go ahead and get started here. First off, I want to just give a thank you to Jeff and Christine Blodgett and Pam, Kyle. Not sure if you guys are in here or not, but thank you for getting everything set up here so that we could run through this webinar and get everybody some CEUs for this. So I have a ton of slides to get through, so I'm going to go kind of fast. Feel free to type your questions into the chat, and I'll try to address them. I'll warn you, I might not get to them. Feel free to reach out to me afterwards, though, if I do not get to your question, just because I do have so much to cover here. So ACNS terminology. For starters, so back in 2012, the American Clinical Neurophysiology Society standardized critical care EEG terminology. They decided to do this because depending on where you learned EEG, you probably describe EEG a little bit different from other people. Back then, before 2012, there was no guidelines as to how to describe it. Everybody had their own system, made communicating to each other very difficult. Like I said, back in 2012, they decided to create a consensus on the terminology for mostly periodic, rhythmic, and fluctuating patterns that you see in encephalopathic or ICU patients. This will allow them then to collect data on these patterns and figure out which ones require treatment and how aggressively to treat it so that they can actually treat based off of just the EEG. And then last year in 2021, they decided to update that. I'll go through and point out a lot of the different updates throughout this presentation as well. Many of them are actually very small, just kind of technicality updates, but I will point those out as well. The main thing, which I've clicked share and you guys should have access to, is this reference chart. It's actually, so this is just the top half of it. It's 2 pages long. Here's the part on background. Yeah, epileptiform findings. The second page is the different modifiers, and then seizures. I went through that pretty quick, but I did share a file here that you guys should be able to get it. Otherwise, this is hyperlinked in my PowerPoint. If you need access to it, let me know. I'll get you this reference chart. This is a great reference to print out and have by your computer if you're going to be describing EEG. It really takes this whole article and condenses it down to 2 pages for you. But let's begin. So to start, they talk about how to describe the background of an EEG. That is, like I said, this very first slide. And I'm just going to go in order here off this chart. So the first thing that you want to make sure you talk about is symmetry. Is the EEG symmetric? I'm not sure how well you guys can see the patterns here, but I have quite a few of these different patterns in here. This is really just pretty basic. It's showing you just a symmetric EEG. I think almost everybody here should know what a symmetric EEG looks like at this point. Like I said, we're starting simple. Your other 2 options for symmetry, if it is asymmetric, it could be a mild asymmetry. This is when the asymmetry is less than 50% on referential recording, or your frequency is off by just half to 1 hertz, and it's present for greater than half of the epoch or record. So this would be an example of what a mild asymmetry looks like. So I'm going to try this whiteboard here and just kind of show you. So here you can see much higher amplitude on the right compared to not much going on there on the left. It's still there, but there's a definite difference between the 2. Can everybody see that whiteboard? There, we'll turn that off. So again, left to right, you can see there is a very small difference, but there is a difference there. So that would be considered a mild asymmetry. Next, then, would be a marked asymmetry, which is going to be more than 50% amplitude or greater than 1 hertz in frequency. This is where that asymmetry is going to be pretty obvious. So here would be an example of a marked asymmetry. Again, with the whiteboard here, you have pretty much nothing going on that left side. All the activity is going on the right side. Very obvious asymmetry. The next thing that you want to mention is going to be the predominant background EEG frequency. Now, this is actually something that they changed in 2021. Again, just another one of those little things. You want to specify what the main frequency of the background is. So is it delta, theta, alpha, or beta? And that's what's new for 2021. Previously, alpha and beta were combined. It was an alpha rate or faster. So now they've actually included beta. That's one of the changes for 2021. If there's 2 or 3 frequencies that are the same, mention both of them. Next, you also want to mention the PDR or the alpha rhythm. And you have to be able to demonstrate it with eye opening. And if there is a PDR, specify what frequency it is. So again, most of us here should know what your PDR is going to look like. This is kind of a compressed page, but you can see this person has a good PDR. They open their eyes, it attenuates. So it's a very obvious PDR. The other option is, there's actually quite a few here for continuous. So another option is nearly continuous. So this would be, but with occasional periods of attenuation or suppression. If there is attenuation or suppression, describe the duration of it. You could have nearly continuous with attenuation or nearly continuous with a suppression. There are two different things there. Again, another change for 2021. It was previously listed as just less than 10% of the record. Now they've adjusted it to be 1 to 9. So another very just little change. And here is a pattern that you can see is nearly continuous, but with attenuation. So this is not suppression. So this is an epoch of a background on an 8-year-old boy. His amplitude is around 115 microvolts. The period to the right, then, there's a brief attenuation down to 25 to 30 microvolts. The very next page on this background jumps back up, and it's actually accompanied by a myoclonic jerk, which you can kind of see the artifact on the far right that is just starting there. Okay, so the next one, then, you can have nearly continuous with suppression. So this is what suppression is. It's completely flat. There's nothing there. So there is a difference there, whether it's nearly continuous with attenuation or nearly continuous with suppression. Next is going to be discontinuous. This is when 10 to 49% of the record is attenuation or suppression. Here's going to be an example of a discontinuous. So this is not burst suppression. This is a discontinuous EEG. Here, this patient was in burst suppression, and as sedation began to be weaned, it became discontinuous before coming all the way back to continuous. So it kind of worked its way along to become more continuous again. Here, the suppression patterns are taking up about 35% of the EEG, so it would be considered discontinuous. Now I got continuity taking up the whole slide here because the next one is going to be burst attenuation or burst suppression. And that's when 50 to 99% of the recording is full of attenuation or suppression, with bursts alternating with attenuation and suppression. Again, just kind of some technicality changes for 2021. They just adjusted the numbers just slightly to make it make more sense. Now, there are a few things when describing burst suppression that they've added in for 2021. This is new. They want you to make sure you tell where the bursts are coming from. So the bursts can be described using the same terms that are used, that I'll get into later when we're describing rhythmic and periodic discharges. Basically, it's generalized, lateralized, bilateral independent, unilateral independent, or multifocal. So where are those bursts coming from? Make sure you mention the typical duration of the bursts and the interburst intervals. And talk about the sharpest component of a typical burst using the different sharpness categories, which we'll talk about later. So again, here is the same patient that I showed you a little bit ago, but this is a few hours earlier when they were actually in a burst suppression pattern. And here the suppression is taking up more than 50% of the record. Also new for 2021 is the presence or absence of highly epileptiform bursts. So if you have a burst suppression patient and you're seeing if the presence, it's present if there's 2 or more epileptiform discharges, so spikes or sharp waves, within the majority of the bursts. These patients, everybody here should be able to tell, okay, yes, that burst is full of spikes. Just make sure to mention that. Also, which is a little bit more confusing, is the presence or absence of identical bursts. So this I'm going to get into a little bit more on the next slide. So these are present if the first half second or longer of each burst or of each stereotype cluster of 2 or more bursts appear visually similar in all channels, which is greater than 90% of the bursts. So let me show you this. You can see on pattern A, these are pretty much all identical for the first half second. With pattern B, each burst is a little bit different, but that same first half second is the same. So this would still be considered identical bursts. So if you have a patient with a burst suppression pattern, make sure to mention if the bursts are identical or if they're not. And lastly, suppression, again, updated because it was previously listed as just the entirety of the record. Now it's greater than 99%. Here too, I think we all know what suppression is going to look like, but I threw a pattern in here anyways. Again, the same patient, but this is when no bursts were present and the EEG was completely suppressed. All right, now a note, bursts must average more than half a second and have at least 4 phases. If they're shorter or have fewer phases, then they're considered single discharges. That we will get to again later, but bursts within a burst suppression or burst attenuation pattern can last up to 30 seconds. Now the next section on that reference chart, so if you just go over one more, is going to be reactivity. Reactivity is considered a change in cerebral EEG activity to stimulation. And you mark that reactivity as either yes, no, unclear, or unknown. Reactivity could include a change in amplitude or frequency, including attenuation of activity. And you should also note the strength of the stimulus used. Muscle and eye blink artifacts do not count as reactive. So here you can see this EEG is reactive to noise. At the very bottom, somebody typed in noise. You got a K complex coming off, and then the pattern switches to more of a beta frequency. So this is going to be a reactive EEG. Now, unclear is used if testing may not have been accurate. So maybe the nurse is walking around the room, but they haven't actually walked up and tried to stimulate the patient. Or if there's too much artifact to assess the response, or if there's maybe a hint of change, but you're not really sure. Document that the reactivity is unclear. Your other option is unknown. Use unknown reactivity when it has not been tested at all. So if that patient's been laying there for the whole period of time, has not been tested, then you don't know if it's reactive or not, then mark it as unknown. There is one other little thing, and that is if the only form of reactivity is stimulus-induced either rhythmic delta activity, periodic discharges, or ictal appearing discharges, then you can categorize it as SERPIDs only. We'll get into SERPIDs later. All right, now in the 2012 version, they had variability and stage 2 sleep transients. These two have now been combined under state changes. I do have a pattern in here, though, that showed variability. And I left this pattern in here. I had this presentation back before the 2021 update, but I wanted to leave it in here because this was kind of a hard pattern to find. And then they went and got rid of it. But this would be what was considered a variable EEG. Here you have, it would go from beta to alpha to theta and just kind of all over the place. So here you can see just in one epoch how on the left you have more of a beta frequency and on the right you have theta. So Angie, reactivity is only documented if purposeful. So reactivity is going to be what if the EEG shows a change in frequency. So up at the very top, so it's a change in EEG activity to stimulation. So you should see a change in either amplitude or frequency is going to be considered reactive. So like I said, what they combined is now called state changes. So state changes are present if there are at least two types of background EEG related to the level of alertness of stimulation. Each of these must persist for at least a minute to qualify as a state. Stimulation should be able to transition them from a less alert to a more alert state, and the changes can occur spontaneously. The more alert pattern is going to be considered the primary reported background EEG pattern. You also want to note whether it is present with normal stage 2 sleep transients, so your K complexes or stems and spindles, or abnormal stage 2 sleep transients. If it is abnormal, specify what the abnormality is. So here's an example of an abnormality of a stage 2 sleep transient. This is on a 7-year-old with an asynchronous sleep spindle. By this age, at 7, you should definitely have some synchronous sleep spindles. So this would be stage 2 with asynchronous sleep spindles. So you can also have state changes present, but without any stage 2 sleep transients, or no state changes at all, and your state changes are absent. Now, the presence of state changes always means that the EEG is going to be reactive. However, reactivity does not indicate the presence of state changes because it might be less than that 1 minute threshold. All right, now this next slide, this is all brand new for 2021. So I had to learn about it myself. And actually, at first, it seemed a little overwhelming, but when you read into it, it kind of makes you kind of think, yeah, I've seen EEGs like that. I know what it is. So this is CAPE, which is a cyclic alternating pattern of encephalopathy. This whole thing is new for 2021. It refers to a change in the background patterns, which may include rhythmic or periodic patterns, lasting at least 10 seconds and spontaneously alternating between the two patterns in a regular manner for at least 6 cycles. I'm going to jump down to the little chart that you see here, and you can see on the very first one you have pattern 1, which looks like kind of like a delta frequency, and then it flips to pattern 2, which is a beta, and then it goes back and forth from pattern 1, pattern 2, 1, 2, 1, 2, 1, 2. If it does that at least 6 times, then that's considered CAPE. And then here you can see where the stim actually happens. Then we go on to a different state change, completely different. But this CAPE would be going back and forth all within that same state. So if that's maybe the patient's sleep pattern that's going back and forth between a delta and a beta frequency, it doesn't have to be that. It can be just any 2 patterns that it's going back and forth between. If you see this, document whether you see it in the patient's more awake stimulated state or the less awake state, if you can tell. Sometimes it's hard to tell. If possible, describe if the pattern corresponds with other things that might be cycling. So maybe their respiratory rate is going back and forth with it. Maybe the heart rate, blood pressure. Maybe you're seeing muscle artifact come and go frequently with it. If each pattern of CAPE lasts less than 60 seconds, then this would qualify, greater than 60 seconds, then it would qualify for the presence of state changes. If CAPE is always present and cannot be interrupted with stimulation, and at least one of the states lasts less than 60 seconds, it remains possible for a patient to have CAPE with no state changes. So this one's all new for 2021. So just if you're seeing this, you can call it CAPE. The next section in background is voltage. This is another thing that's new for 2021 is high voltage. I think when they were writing it, they just kind of forgot high voltage. Before, the only options were normal, low, and suppressed. now they've added in high. I'm sure most of you will know to associate high voltage with hypsarrhythmia. So first thing you'd want to do here so that you can actually see that EEG is adjust your sensitivity. Again, your other options are normal or low, where most or all of your activity is less than 20 microvolts. Here would be an example of a low amplitude EEG. Again, we're on a sensitivity of 7 up at the top. There is activity going on, but it's just kind of hard to see. This would be one that you'd want to increase your sensitivity to see a little bit better. The other option is going to be suppressed, which is all activity less than 10 microvolts. Again, here's that same suppressed pattern before. So suppression is listed as both under both voltage and under continuity. Now the next thing to mention is going to be the anterior-posterior gradient. And this is just going to be either present or absent. And your anterior-posterior gradient is going to be very simple. We'll just go to this pattern again, showing PDR. Here, your alpha is going to be higher in the posterior electrodes. So anterior to posterior, it gains an amplitude. Now the opposite is going to be a reverse anterior posterior gradient. And this is defined identically, but it's reverse. It's a posterior to anterior gradient of voltages and frequencies. And this is going to be in a pattern like this one, which would be considered an alpha coma. You have your alpha more frontally dominant and decrease in amplitude as you go towards the back. And then the last thing in background is going to be breach effect. Your options are whether it's present, absent, or unclear. I think everybody should know here what a breach effect is. So just going to skip over that one. All right, let's go on to sporadic epileptiform discharges and the rhythmic and periodic patterns. So this is sections B and C on that chart. So if you look at that chart that I referenced, B is going to be on the far left, and it's kind of a short little section. The main thing that it's going to tell you is for non-rhythmic, non-periodic spikes, polyspikes, and sharp waves. You should categorize them on how frequently they're occurring. Your options are going to be abundant, frequent, occasional, and rare. Sorry. If we move on then quickly to rhythmic and periodic patterns. Sorry if I'm going kind of fast, but there's a lot of information here. So rhythmic and periodic patterns, this is going to take up the big chunk of all of this. This is going to be your terms must consist of two main terms and then add modifiers as appropriate. So main term 1 is always going to refer to the location of the pattern, the localization. Where is the pattern coming from? Main term 2 is going to specify the type of the pattern. So for main term 1, first is generalized. Everybody should know what generalized is, but it does include any bilateral, bisynchronous, or symmetric pattern, and it may have a restricted field, such as frenally, occipital, or midline predominance. You also have lateralized, which is going to include unilateral and bilateral synchronous, but asymmetric. Again, this can be focal, regional, or hemispheric. New for 2021 is going to include bilateral asynchronous under lateralized. This is going to be a pattern that consistently begins in one hemisphere, but then shifts to the other. And if you look at this pattern, you can see the periodic discharges start on the left, and about a second later, they come through on the right. So that's going to be a difference. This is going to be considered the bilateral asynchronous. Another option is bilateral independent. So this refers to the presence of two independent lateralized patterns, so one in each hemisphere. You can see this patient has some sharp activity going on. I'm assuming this is left side based on the pattern that it's showing. You have kind of some sharps occurring independently on the left from the right. Next is unilateral independent. This person's going to be pretty sick. So 2 independent patterns occurring within the same hemisphere. So here you can see this patient has 2 different sets of periodic discharges going on, but they're both occurring on the left. In unilateral independent periodic discharges, they'll occur at 2 independent locations, but at the same time and within the same hemisphere. And then lastly is multifocal. This refers to at least 3 independent lateralized with at least 1 in each hemisphere and all 3 or more occurring simultaneously. These are the patients that you log on to and it's a mess and you know it's going to be a pain of an EEG to watch. All right, now a few notes on localizing lateralized patterns. Unilateral is seen really in just 1 hemisphere. Make sure you note what side it's on, so whether it's the left or the right. With bilateral asymmetric, if it's seen bilaterally, but clearly and consistently a higher amplitude in 1 hemisphere, then it's referred to as lateralized bilateral asymmetric. For example, if you have periodic discharges that are seen bilaterally and synchronously, but consistently greater on the left, then you'd want to refer to them as left LPDs bilateral asymmetric. Bilateral asynchronous is seen bilaterally, but clearly and consistently with a lead-in from the same side. That's kind of the same. You would maybe call it bifrontal LPDs that are consistently earlier on the left. But again, be sure to specify the time lag between the sides as well. A lateralized pattern can be both bilateral asymmetric and bilateral asynchronous and still be considered a lateralized pattern. And then for unilateral independent patterns, make sure to specify which lobe the pattern is each pattern is happening in. So talk about both of them. So if I could go back here, so here's the unilateral independent. Make sure you talk about both of them and say which lobe it's coming from, whether it's temporal lobe, frontal lobe, occipital lobe. Talk about both of them. All right, skip back ahead here. For localizing bilateral independent and multifocal patterns, symmetric is approximately equal in both hemispheres, but with no consistent asymmetry. Patterns that are bilateral independent and symmetric should be called bilateral independent symmetric or multifocal symmetric. Asymmetric is clearly and consistently more prominent on one side. And again, it would just be listed as bilateral independent asymmetric or multifocal asymmetric. But then you'd also want it followed by left greater than right or right greater than left. Next, we have main term 2. And this is going to be the type of pattern that you're seeing. So we have periodic discharges. Periodic is defined as a repetition of a waveform with relatively uniform morphology and duration with a quantifiable interdischarge interval between consecutive waveforms and the recurrence of the waveform at nearly regular intervals. The discharge is defined as waveforms lasting less than half a second, regardless of the number of phases, or waves greater than or equal to half a second, no more than 3 phases. This is opposed to bursts, which are waveforms that last greater than or equal to half a second and having at least 4 phases. So discharges and bursts must clearly stand out from the background activity. Rhythmic delta activity. Rhythmic is defined as repetition of a waveform with a relatively uniform morphology and duration, and without an interval between consecutive waveforms. So rhythmic is actually defined. So when you have a pattern that you can't say it's kind of rhythmic or it looks a little rhythmic. There is actually a definition of rhythmic. So here it is. It's defined as a repetition of a waveform with a relatively uniform morphology and duration, without an interval in between. An example of a rhythmic pattern would be a sinusoidal waveform. Although there are other examples, a pattern can be sharp at the top or at the bottom and still be considered rhythmic, although it wouldn't be sinusoidal anymore. Irregular or polymorphic delta should not be reported as rhythmic delta activity. Rhythmic delta activity is either half to less than 4 hertz. And if a pattern qualifies as both periodic discharge and rhythmic delta activity simultaneously, then it should actually be coded as PDs plus R rather than RDA plus S. We'll get into those plus modifiers here in a little bit. And then lastly, you have spike wave and sharp wave. This is considered polyspike, spike, or sharp wave consistently followed by a slow wave in a regular repeating and alternating pattern with a consistent relationship between the spike component and the slow wave for at least 6 consecutive cycles and with no interval between. If there is an interval, then this would qualify as periodic discharges, whereas each discharge is a spike and wave. All right, so now we're going to get into the modifiers. So this has its own page, basically. So you have major modifiers, minor modifiers, and then the plus modifiers. These are all things that you should mention when you're describing either RDA, periodic discharges, or spike and wave. The first is going to be the prevalence. How often are they occurring? This should be based on the percent of seconds that include and are within the pattern. The time between widely spaced periodic discharges counts as part of the pattern duration. So here's your 5 options: continuous, abundant, frequent, occasional, and rare. So document how often they're occurring. Next, you have duration. So specify the typical duration of the pattern if it's not continuous. It could be very long, and intermediate duration, brief, or very brief. You can see the intermediate duration they updated in 2021. This was to match the definition of focal status epilepticus. Next, you have the frequency. So again, rate per second, record the typical minimum and maximum frequencies. And for rhythmic delta, it has to be less than the 4 per second. A couple of new notes for frequency for 2021. So for periodic discharges and spike wave, your typical frequency is less than 2.5 hertz and can only be applied to rhythmic and periodic patterns that are less than a 10-second duration. If periodic discharges or spike wave have a typical frequency of greater than 2.5 hertz and are greater than 10 seconds, then these would qualify as electrographic seizures and should be referred to as such rather than periodic discharges or spike wave. Also, no rhythmic or periodic patterns can have a typical frequency of greater than 4 hertz. If a rhythmic periodic pattern is greater than 4 hertz and greater than or equal to half a second, it would always meet the criteria for either birds or an electrographic seizure. If it's less than half a second, then this would not qualify as the rhythmic periodic pattern, but it might qualify as a polyspike. All right, you also want to include the number of phases. So 1 plus the number of baseline crossings of the typical discharge. In a longitudinal bipolar and in the channel in which it is most readily appreciated. This applies to periodic discharges and the entire spike wave complex, so include the slow wave. This does not apply to rhythmic delta activity. You should also talk about the sharpness. For both phases, describe the typical discharge. Again, this only applies to periodic discharges in the spike sharp component of spike wave, not rhythmic delta activity. So it can be categorized as either spiky or sharp. So this is actually a very different. So this, you can see the predominant phase is the greatest amplitude is considered the sharp, and the sharpest phase up above here is what would be considered spiky. All right, for sharpness, specify for both the predominant and the sharpest phase if it's different. So we're going to add in here sharply contoured. So this is going to be used for theta or delta waves that have a sharp wave morphology. So a steep slope on one side of the wave and are pointy at its inflection points, but are too long in duration to actually count as a sharp wave. This would be labeled as sharply contoured. Here you have some sharply contoured LPDs. This is not LPD plus S, because the S modifiers for for sharply contoured only applies to RDA. So this would be sharply contoured LPDs is how you would describe this pattern. Your other option for sharpness is blunt, so having a smooth or sinusoidal morphology. Here is some evolving LRDA. It's lateralized rhythmic delta activity that evolves in frequency and morphology from a 4 per second blunt rhythmic delta activity to a 2 per second sharply contoured rhythmic delta activity. So on the far left here, it starts off as much more of a blunt pattern. All right, we also need to mention the amplitude. So a typical amplitude is measured in a standard bipolar recording. For periodic discharges, this refers to the highest amplitude component. For spike wave and for spike wave, it refers to the spike sharp wave. The amplitude should be measured from peak to trough, either high, medium, low, or very low. Now for periodic discharges, there is a absolute and a relative amplitude. The absolute amplitude is measured from the very top to bottom. You can see this A on the outside here on this whiteboard. So the A, this is going to be your absolute amplitude, and then your relative amplitude, which is going to be here. Difference between. Sorry, I can't draw that very well on there. This does not include sporadic waves of the higher amplitude. Turn the whiteboard back off there. So here you can see sharp LPDs that have a high absolute amplitude of greater than 200 microvolts, but a relative amplitude of greater than 2. So I'm going kind of fast through this part because we have a lot to cover and running out of time. So stimulus induced is another modifier that you need to make sure you mention for both for reproducibility brought about by an alerting stimulus. It can be either with or without clinical alerting. It may also be seen spontaneously. If never clearly induced by stimulation, reported as spontaneous. If it's unknown, unclear, or untested, reported as unknown. Make sure you specify the type of stimulus. So it could be non-noxious stimuli, such as auditory, light tactile, patient care, or noxious stimuli, such as suctioning, sternal rub, or nostril tickle. So here you can see this is a stimulus-induced GPDs with noxious stimuli. Right there in the middle, you can see that they do a sternal rub, which brings about the LPDs on the right side of the pattern. And then here, this is kind of hard to find in a single epoch from non-noxious stimuli. You can see the discharges here in the kind of right central region. The discharges sometimes may take 15 to 20 seconds to start up. If it's from non-noxious stimuli, you can see staff enters the room here. You got a calm EEG on the left. When the staff enters, a few discharges start up there. All right, next we have evolution. So you can mention whether it's evolving or fluctuating. Both terms refer to changes in either frequency, location, or morphology. If neither term applies, then report it as static. Changes in amplitude alone would not qualify as evolving or fluctuating. So evolving means at least two unequivocal sequential changes in frequency, morphology, or location. Evolution in frequency is defined of at least two consecutive changes in the same direction by at least half a second. Here you can see LPDs that start out at about 1 per second and increase to 2 or 3 per second, and then all the way up to about 8 per second. So this would be evolution. Evolution in morphology is defined of at least two consecutive changes to the morphology. So this is, again, a very difficult pattern to find, but it's generally, mainly because it can take a few seconds to achieve. If you note the sensitivity here, this is actually on a 30. This is in the very middle of a seizure. You can see the sharp waves toward the start of the epoch shift to more of a spike toward the end of the epoch. So this is going to be evolution in morphology. Evolution in location is defined as sequentially spreading or sequentially into or out of at least two standard electrode locations. So evolving location is quite a bit more common. Here you can see the seizure starting in the right posterior quadrant at the start of the record and quickly spreading over the right side and some onto the left by the end of the epoch. To qualify as evolving, a single frequency or location must persist for at least 3 cycles. In morphology, each different morphology or each morphology plus its transitional forms must last at least 3 cycles. So spiky 4-phase periodic discharges for 3 cycles, then sharp 2 to 3-phase periodic discharges for 3 cycles, and then a blunt diphasic periodic discharge for 3 cycles. The criteria for evolution must be reached without the pattern remaining unchanged in frequency, morphology, or location for 5 or more minutes. An example that would not qualify would be something that lasts 3 per second for 1 minute, then 2 per second for 7 minutes, and then 1.5 seconds for 2 minutes. Fluctuating then is defined as greater than or equal to 3 changes, not more than 1 minute apart. Again, in frequency, morphology, or location, but not qualifying as evolving. So fluctuating would be from 1 to 1.5 to 1 to 1.5, spreading in and out of a single electrode. That would be considered fluctuating, but it's not evolving because it doesn't take that 3rd step. It's just back and forth between the two. Yep. An example that would not qualify for fluctuating would be 2 per seconds for 30 seconds, then 1.5 seconds for 30 seconds, and then 2 per second for 3 minutes, and then 1.5 for 30 seconds, and then 2 for 5 minutes. The changes are just too far apart. They're greater than a minute. An example that would qualify, 2 per second for 10 seconds, then 2.5 for 30, then 2 for 5, then 2.5 for 5. You're going back and forth, but all within that minute time frame. All right, next we have the plus modifiers. I'm really running out of time, so I'm going to go as fast as I can here. So it's an additional feature that renders the pattern more ictal appearing than the usual term without the plus. It does not apply to spike waves. So this is just for periodic discharges and rhythmic delta activity. So you can have a periodic discharge plus F. This is when it includes superimposed fast activity, so theta or faster, rhythmic or not, with each discharge. Here you would have LPDs plus F, as you have some spiky LPDs that are superimposed burst of low amplitude fast activity are kind of highlighted in the boxes. You have PD plus R. This would be superimposed rhythmic or quasi-rhythmic delta activity. So here you have LPDs plus R. It's irregular morphology and repetition rate. Quasi-periodic discharges with superimposed quasi-rhythmic delta activity in the right hemisphere with occasional spread to the left. This is a less stable pattern and more ictal appearing than just the LPDs by themselves. Then you have RDA plus F, which is superimposed fast activity. Not the most rhythmic delta, but it'll work for a pattern. You can see the faster activity writing on top of it here. And then RDA plus S, which is frequent intermixed sharp waves or spikes. Frequent is defined as more than one sharp or spike wave every 10 seconds, but it's not periodic discharge. Or the rhythmic delta activity is sharply contoured. So here you can see you have some generalized rhythmic delta activity, and here, in this case, it would be sharply contoured. You also have, now you can have both PD plus FR or RDA plus FS. In this pattern, you have fluctuating LPDs plus FR. As the sharpest and most prominent components of the pattern differ, it would qualify as both spiky and sharp. And here is some fluctuating LRDA plus FS. You got superimposed fast activity that could qualify for the plus F if it were present with just the RDA and absent from the background. Which you can't really tell from just this page, but. All right, then you have bilateral versus unilateral. If a pattern is bilateral and qualifies as plus on one side, but not on the other, then the overall main term should include that plus. So here you have bilateral periodic discharges plus F. So BIPD plus F. At a rate of about 0.5 to 1 per second. Most prominent centroparietally on both sides. The periodic discharges have a sharp morphology and are associated with a low amplitude, sharply contoured rhythmic fast activity, especially posteriorly. More prominent on the right, where the fast activity is nearly continuous. Similarly, generalized rhythmic delta activity with superimposed spikes on one hemisphere would qualify as GRDA plus S. So here'd be, here you have generalized delta on the right side. It's a bit faster with a sharper morphology. Note on the plus F, if a pattern qualifies as RDA or periodic discharges has superimposed continuous fast frequencies, this can and should be coded as plus F if the fast activity is not present in the background activity when the RDA or PDs are not present. Coded as plus F if the superimposed fast activity is part of the RDA or PD periodic discharge pattern and not simply part of the background activity. So polarity, again, just specify for the predominant phase only. And should be determined on a referential montage whether you got a positive polarity. So here you have GPDs with a positive polarity or a negative polarity. Here's some sharply contoured LPDs with a negative polarity. Or whether it's a dipole or unclear. Describe the typical discharge. This applies to periodic discharges and spike sharp components of spike waves, but not RDA. And then we have some minor modifiers. These I'm going to fly through kind of fast. Quasi is used to modify rhythmic or periodic as in quasi-rhythmic or quasi-periodic. It's preferred over using the word pseudo or semi. The distinction is to be applied only if determined by quantitative computer analysis, so not by visual impression. So basically when the computer analysis calls something, but you don't agree. Describe whether it's a sudden onset or a gradual onset. This is preferred over the word paroxysmal. Sudden onset is defined as progressing from absent to well-developed within 3 seconds. So here you can see an absence seizure starting on the right side is going to be a sudden onset event. Another minor modifier is triphasic morphology, which will apply to periodic discharges or spike wave. Either 2 or 3 phases, with each phase longer than the previous, and the positive phase with the highest amplitude. If 3 phases, this must be negative, positive, negative in polarity. Here you can see GPDs with triphasic morphology. If it's 2 phases, this must be positive, then negative. A biphasic waveform may be categorized as triphasic by this definition. In the typical appearance of the triphasic wave, phase 2 is the most prominent, and phases 1 and 3 are of similar amplitudes. All right, another minor modifier is an anterior to posterior lag or posterior to anterior lag. This applies if it's consistently measurable greater than 100 milliseconds. Make sure to specify the typical delay in milliseconds. Again, a lot of times seen with triphasic. You can see this arrow up here in the top right. The same GPDs with triphasic, but now this is showing the anterior posterior lag. You can see how it starts towards the front and it shifts as we go towards the posterior. And then the reverse, the pattern in the square up here at the top, you can see there's a posterior to anterior lag in the second positive component of the triphasic phase. It shifts over. So let me turn on this whiteboard. How do I hide this? Nope, it won't let me turn it off. Okay, never mind. I'm not going to play with it. I don't have enough time. Just going to move on. You guys can see it in the box there. All right, so next is epileptiform discharges. So epileptiform discharges, the quantification and categorization of sporadic epileptiform discharges. This includes sharp waves and spikes as previously defined. So again, just how frequent they're occurring, whether it's abundant, frequent, occasional, and rare, and then what those times are. So 1 to 10 per second, but not periodic, is abundant. More than that, but less than a minute is frequent. More than a minute, less than an hour is occasional. And rare is considered less than 1 per hour. Again, here's our absence seizure. This is going to be considered abundant. These are going to be, again, considered abundant because of how frequently they're occurring. Or, I'm sorry, these are going to be periodic. So these would not qualify as as abundant because these would be periodic. All right. Oh, you know what? Oh, shoot. My last few slides are not in here. Shoot. All right, well, I'm going to go up on, let's see. I had added in the section for electrographic and electroclinical seizures, but I must have given Jeff the wrong PowerPoint, so that's my bad. I didn't look all the way through it like I should have, so I'm going to come to my slides here, and I'm going to stop this for a second and just go to start from the beginning here again. Let's see. Well, I guess while I try to figure this out, I guess we're kind of at the end for time anyways. So does anybody have any questions?
And you can ask questions either by entering them into the chat area, or you can raise your hand with that hand icon to speak, and we'll let you ask it verbally.
Jeff, is there a way for me to go to a certain slide, or can I only go to them one at a time?
I think you have to go through them. What you could try, Tom, is if you've got the slides on your computer, you can share your screen. That is you can do a screen share, so you might be able to bring them in that way.
You know what? We are out of time anyways. So how about this? If anybody wants the full PowerPoint where I have the rest of the slides that go into talking about seizures as well, since we're out of time, just shoot me a click or an email and I will just send it to you. Kimo, there's not really a download. The links that I have in here are going to be for that reference chart and then the actual paper that was written for the ACNS terminology. But I can send you this whole PowerPoint. I'll just send it to you in an email.
Very good. Thank you. And thank you, Tom. That was great. And I'll close out the room now, and we'll have the recording available within 2 days. Very good. Thanks, Tom.
All right. Thank you. Thanks, everyone.